Dr. Bill Moss, Executive Director at IVAC. Before we get started, I want to let participants know that we will have a short Q&A session at the end, so please enter your questions into the chat box and we will get to them after the presentation. Any questions we do not address, we can follow up individually with after the webinar. This webinar will be recorded. Thank you for attending. I'll now hand it off to Dr. Bill Moss to introduce IVAC in today's presentation.
Greetings, everyone. My name is Bill Moss, and I'm the Executive Director of the International Vaccine Access Center here at the Johns Hopkins Bloomberg School of Public Health. It's my great pleasure to introduce this first presentation of IVAC's World Immunization Week webinar series. Before we get into the presentation, I'd like to tell you all a little bit about IVAC. IVAC, or the International Vaccine Access Center, is a center within the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Our work is rooted in the evidence to policy to access value chain for vaccines. We help synthesize and generate evidence to inform policy and direct policymakers on improving access to new and old vaccines. We work across a broad range of practice areas, including disease epidemiology, country support, and economics and finance, as you'll hear about today. We also have technical leadership across more than 15 different diseases and syndromes that are vaccine preventable. Our IVAC team works across 40 different countries. We're comprised of more than 50 faculty and staff, including physicians, professors, economists, epidemiologists, researchers, and advocates. Last year, IVAC celebrated its 10th anniversary, and it was founded by Dr. Oren Levine, now at the Bill and Melinda Gates Foundation, and his leadership was succeeded by Dr. Kate O'Brien, now the Director of Vaccines, Immunizations, and Biologicals at the World Health Organization. IVAC is hosting a number of World Immunization Week activities, and I invite you to participate and join us in all of these. Tomorrow, we'll be hearing about VOICE, using high-impact evidence for immunization advocacy. The VOICE is a website and tool of the Value of Immunization Compendium of Evidence, and that presentation will be made by Victoria Chu and Alexandra Mitchell. On Wednesday, we'll hear about, are we ready to deliver COVID-19 vaccines to older adults by Lois Priver-Dumb. And then on Thursday, we'll hear about protecting vaccine programs in the era of COVID-19 from Anita Shett. Today's presenters will be talking about measuring the economic impact of vaccine. And we'll have Brian Pattenow, an economist at IVAC and assistant professor of economic evaluation at the Johns Hopkins Bloomberg School of Health in the Department of International Health. Brian is the principal investigator of the 4th iteration of the Decades of Vaccine Economics project. He will be joined by Libby Watts, a research associate on the economics and finance team here at IVAC, and she works on economic models for the Decade of Vaccine Economics project, the DOVE project, and the TIVAC Cost of Illness project in Nepal. Brian, I'll turn it over to you for the presentation.
Thanks, Bill. So I'm going to talk about in this webinar a bit about the work that was done under the Decade of Vaccine Economics project, which is about measuring the economic impact of vaccines. Next slide, please. So the main question that this entire thing hinges upon is, how do we measure the global impact of investing in vaccines? And why do we do this? So our objective is going to be to determine the return on investment of immunization programs against 10 antigens in 73 current and former Gavi-supported countries. And we measure return on investment as the benefits of the immunization programs minus the costs divided by costs. Next. So why return on investment? Why are we attempting to monetize these investments that we know have large health implications? So investment in health, as we all know, is needed to achieve progress towards the Sustainable Development Goals and the national health objectives. Return on investment is used by the global health community as a way to describe value and articulate the need for new investments. Additionally, it's a way to compare investments in the health sector to investments in other sectors that may not have mortality or morbidity outcomes. So for instance, education or infrastructure or social security and things like that, to allow you to compare between investments in one sector and another. In previous ROI estimates generated by previous iterations of the Decade of Vaccine Economics project under Ozawa et al., helped to catalyze resource mobilization for the Decade of Vaccines. And now new projections are needed going forward that we've come to an end of this decade, ending this year in 2020, to figure out how much return we can expect in the future. Next. So just to give an idea of what the project scope is, right here we can see the different antigens that are covered in our models. So we include vaccines against 10 antigens, including measles, yellow fever, Hib, Japanese encephalitis, hepatitis B, MenA, rubella, streptococcus pneumonia, and HPV and rotavirus. And we cover 73 current and former Gavi countries spanning Afro, AMRO, EMRO, Euro, CERO, and WPRO regions. And we split this by 2 decades. So again, we'll talk about return on investment and economic benefits that are derived for the Decade of Vaccines. So historical evidence from 2011 to 2020 and projected future ROI based upon our modeling for the future decade, which will be from 2021 to 2030. Next. So to give an overview about the methods that will be discussed in this presentation and that Libby will get into in more depth in a moment, we're going to split it into benefits and costs. So the immunization program costs over on the left in light blue are going to encompass things like the doses and the delivery costs, which we'll get into in a moment. Benefits we're going to split into 2 different categories, which we'll go into in more detail. One of them is a cost of illness averted method, which seeks to monetize the sort of direct costs associated with vaccine immunization programs. And then we have a value of statistical life approach, which attempts to capture some of the broader benefits associated with improving health in general. Next. So to take a look at immunization program costs and how we compute and deal with program costs for delivering these vaccines in our 73 countries. We split our immunization program costs into 2 key areas. One are the cost of vaccines as a commodity, which is price times the number of doses. So we get price from Gavi actual prices for the time period where there is good data on prices recorded, so 2011 to 2017. And then Gavi price forecasts for the different vaccines that we cover going forward. We then utilize, and in order to forecast prices going up into the future, we use a demand forecast as well. For doses, we use a demand forecast for 2011 to 2030 based on demographic data and coverage data that's available for the different vaccines to get this vaccine cost. But we all know there's a lot more than just the actual cost of commodities that go into delivering vaccines. There's labor costs, there's the cost of transportation and cold chain, there's the cost of shipping, there's the cost of delivery. So there's a lot of other things. And we group those together under immunization delivery costs, which again is a unit cost per dose for each of the different vaccines that we have times the number of doses. And the data for these types of delivery costs come from a number of different sources, including the comprehensive multi-year plan costing tools from the WHO, the immunization delivery cost catalog, Gavi budget proposals, systematic reviews of the costs of delivering vaccines in different settings, particularly for campaigns. And doses again come from demand forecasts based on demographic data and coverage data for the countries that we cover in our models. Next. So here we have an idea of what the overall costs of immunization programs in these 73 countries that cover our antigens look like. And these are split again by decade and then overall. So for the 2011 to 2020 period, total costs were $21.7 billion. And projected going forward, those costs are going to increase to around $36.2 billion for a total over the 20-year period of $57.8 billion. And you can see that we expect these costs to be split roughly 1/3 of the costs in the future decade, or a little bit more than a third, going to delivery, and the rest to vaccine dose. And it's split fairly evenly in 2011 to 2020 between vaccine dose delivery, vaccine doses and delivery. And we expect this increase in the next decade due to the more expensive cost of some of the newer vaccines that are being introduced, as well as expanding coverage in a number of different settings. Next. You can see here how the vaccine program costs break down over time between the different between the different antigens that we are using the vaccines against. So we are at the 2020 time period, and you can see the differences between what we have seen in costs before and anticipate costs going forward into the future to look like, broken down by different vaccines. Particularly what you can see from this is that vaccines that are relatively new and are being introduced for the first time in some countries, like HPV, and then pneumococcal, will see an increase in the share of costs that they contribute to over time, while long given and historic vaccines that have high coverages in a lot of areas will maintain similar costs to maintain those coverage levels. So you can sort of see the breakdown and what the cost structure is expected to look like going forward and what it has looked like historically. And now I'll hand it over to Libby to give an introduction to the benefit side of this ROI equation. Next. I think you may have to unmute Libby.
All right, hi, can you hear me?
Yep.
All right, I'll try not to do that again. Okay, thank you, Andrew. And I am missing the slides here. Are you sharing your screen? Okay. All right, so transitioning over to looking at the economic benefits, I will talk about both methods that we use to estimate the economic benefits of vaccines. And the first method is the cost of illness approach. This is looking at the observable impact of vaccines on the health system, households, and labor productivity. So we receive estimates of cases and deaths averted from the Vaccine Impact Modeling Consortium at Imperial College, and we use these to estimate short-term and long-term costs averted. Short-term costs include treatment and transportation costs. Treatment costs are estimated by multiplying the care-seeking rate by the cost of treatment at various health facilities, which we get from the WHO choice model. And transportation costs are the cost per round trip to a health facility for each instance of care seeking. We also estimate caregiver wages lost from time spent taking a child to a health facility. Long-term costs include productivity loss due to disability, which we estimate by multiplying the years of disability by the GDP per capita, which we use as a proxy for the value of productivity, and then adjusting that by the appropriate disability weight from the Global Burden of Disease study. We also estimate productivity loss due to premature death. And this is the value of future earnings at the age of death. In our model, we assume that the labor force participation rate is 100% because the official labor force participation does not typically include workers in the informal sector, who make up a large proportion of the workforce in LMICs. And then we sum all of these costs together to estimate the cost of illness averted by vaccination. So this is the primary approach that we use to estimate the economic benefits. So next I will talk about the secondary method that we use. Next slide. The second approach is a broader view of the economic benefits called the value of statistical life, or VSL method. And VSL is derived from a person's willingness to pay to reduce their risk of death, and is the average value that society places on saving a life without respect to a person's wage or productivity. VSL may encompass things that we don't normally think of as having an economic value, such as a sense of community, spending time with one's family, or passing on traditions. VSL is commonly used in high-income settings when evaluating policies that have an impact on mortality. The US VSL is a robust estimate of this, and it's derived from both willingness to pay surveys and wage risk studies. And it was approximately $10 million in 2018. Unfortunately, in the 73 Gavi countries that we include in our model, there are very few direct estimates of VSL. And this is because there are not standardized methods for estimating VSL in these settings, and there's limited capacity to do these studies. Because of this limitation, we extrapolated the US VSL to these countries using the value transfer method, which adjusts for differences in income between two populations. And you can see the calculation that we use over on the right. The adjustment factor is based on a ratio of the GDP per capita in the low-income country compared to the GDP per capita in the US. Using the country-specific VSL estimates, we calculate the total economic benefits by multiplying the number of deaths averted by vaccination in each country and year. Next slide. This graph shows our estimates for the economic benefits over the 2-decade period. So using the cost of illness approach, we estimated the economic benefits to be approximately $1.5 trillion. And using the VSL method, our estimate was about double this at $3.2 trillion. On the right-hand side, you'll see another estimate of the economic benefits, which uses a method similar to VSL, but it is age-adjusted. And instead of assigning the same VSL to all deaths averted, it values children's lives more heavily because it is calculated using the number of life years saved. And since vaccine programs primarily impact children, this is an even higher estimate derived than the standard VSL approach. So overall, we found that the economic benefits of vaccination are equivalent to between 1 and 3% of GDP in the 73 Gavi countries. So the next step is to compare the economic benefits to the costs and calculate the return on investment, which Brian will now discuss.
Thanks, Libby. So we can see from these disparate calculations through benefits and costs, we can combine them to create an ROI. And what the ROI is telling us, or return on investment is telling us, is what is our return for one marginal dollar invested in vaccines, or one average dollar invested in vaccines in this case. So what we find is that for the decade of vaccines from 2011 to 2020, $1 invested in vaccines saves $28.5 in averted costs of illness. So every dollar is saving 28.5 using that approach. If we use the value of statistical life approach and encompass more of the other demand side things, as Libby mentioned, that are difficult to quantify in productivity or averted cost terms, like enjoyment of life and just willingness to pay to be healthy, then we capture $54.6 for every dollar invested in economic benefits during the decade of vaccines. Can you click again for the next animation, Andrew? If we move forward into the future decade from 2021 to 2030, we see that, again, for cost of illness, we get about 21 to 1 for an ROI. So $1 invested is saving $21 in averted cost of illness. And from a VSL perspective, is giving us a benefit of, again, approximately $54 for every $1 invested. And you can see here the different trajectories of how these estimates are predicted to go over time and how they have gone in the past. VSL is staying relatively constant in its relationship to cost. So you can see the very small dark blue bars at the bottom are representing costs. And although they're small, we can see that they're growing over time, and particularly growing between the decade of vaccines and the next decade. Again, this is reflective of vaccine programs expanding their coverage in countries, trying to reach harder to reach populations, as well as introducing new vaccines in various countries where those vaccines have not been introduced and where the initial price for introduction is expected to be more expensive than some of the vaccines that have already been introduced in those settings. So we can see that cost is anticipated to rise. But along with that, benefits are also rising. You can particularly see the VSL benefits anticipated to rise because as countries develop and GDP rises in those countries and cost of living rises in those countries, VSL is anticipated to rise as well, given its relationship to the US in terms of VSL and GDP. And the cost of illness approach we're seeing hold relatively stable at the number of benefits we're expecting to see based upon the averted health system costs, even in the face of rising costs of program implementation. So regardless of which decade you're looking at, vaccines have a huge social return on investment. Next slide, please. So what are the policy implications for all of this, and why are we doing this again? So the policy implications are largely for advocacy purposes to show how much of an investment and to reframe the idea of health programs as investments rather than just costs on budgets. So ROI figures are used in advocacy campaigns to sustain funding and support for immunization or to advocate for future funding. We've used these numbers and they've been adopted to be used in the Gavi investment case for the replenishment that's occurring this year. So you can see here some data from Gavi and some tweets from Gavi that have discussed these findings. And we also hope that these estimates can be useful for others hoping to compare investments, social impact investments, to other things that maybe never had a value attached to them before that was something like the ROI. So this can be used to compare, again, things that have non-health benefits with health benefits. Next slide. So we'll open it up in just a moment for question and answers.
Yes, please go ahead and enter any questions you have into the chat box. I'm also going to be unmuting lines. Should be able to unmute yourself now.
Yeah, hi, Brian. Brian, very good presentation. I actually followed up the developments and how you produce the models. One quick question that I have is whether an observation that I did not see oral cholera vaccine. I'm not sure whether you have that in the pipeline to do some economic modeling or maybe not. Thank you.
So I think that based upon what we have, we do have the potential to do future economic modeling based upon everything we have. And obviously there's going to be a lot of needs for different types of modeling to be done off of this. One of the other future directions that we intend to go in with this work is the numbers and estimates that are generated here are largely aggregate. They're at a high global level. They're meant to sort of be a good informer of the value that we've seen across countries, but they're maybe not so specific to what's going on within a specific country at a specific time. And for those, we need a little bit more of the subnational nuance that goes into vaccine program delivery by region or by sub-region, and the nuances related to cost based on their specific plans within the countries to take over different portions of their vaccine program from Gavi or to expand in different ways than may have been forecasted. So what we're planning to do is move these types of models to be more flexible at the country level and allow for individual country computation of particularly economic benefits. Does that answer your question?
Well, not specific to the oral cholera vaccine.
Oh, yes. So right now we are considering expanding this to other vaccines as well. There's a few that are missing from our list that you can see that we would like to expand to in the future. And we're working with partners to try and combine epidemiologic and economic models for these future vaccines.
Okay, that answers my question. Thank you.
Yeah. Do you want me to just take questions from the chat box, or should I wait for people to talk, Andrew?
You're welcome to take them from the chat box. Just trying to look through them right now. Some people asked to go back to different slides, so.
I'll answer. So one question we have here is, do you think the value of a statistical life result would be different if it was measured in a low and middle income country compared to a high income country setting? And how you aim to investigate that? So one of the components of this project that we didn't discuss in this, which is more of a methods project, was to assess value of statistical life through stated preference methods in one of these low and middle income countries. So we piloted methodology in Bangladesh to compute the value of statistical life in Bangladesh. And we get order of magnitude multiples of GDP from what we get in that setting. It varies strongly by setting. I've done some other work outside of this particular study to take a look at VSL in Tanzania and other countries. And it's a bit mixed on what the relationship is between VSL derived from the countries, like high income countries such as the United States, versus VSL derived in countries. Sometimes it's about the same, sometimes it's less, sometimes it's more. And it's very sensitive to the methodology used. So I think that we're still not quite at a place in the research where we have a uniform way of robustly calculating this that winds up being standardized across countries. So that was part of the rationale for the VSL approach taken in our studies, but certainly, hopefully in the future, we can think about, how this might be different by computing it from low and middle income countries directly. Another question I have here is, where can we get country by country analyses, and why these 10 antigens? So these 10 antigens were chosen because they were studied under the initial phases of the Decade of Vaccine study, which measured the impact up through 2017 and projected it, or 2016 and projected it through the future to 2020 for the Decade of Vaccines. And we wanted to check back on those estimates, which covered these certain vaccines, to see, how have we done compared to what we thought we were going to do in that study, and what are our projections going forward. So that's the reason for these 10 antigens. For country by country analyses, again, we're starting to work with some countries to try and generate estimates for them, but we haven't quite gotten to that stage. We currently aren't presenting country by country analyses yet, but we do have some estimates of return on investment by region.
Hello, can I ask a question?
Yes.
Yeah, I was just looking at the slides for the cost. I'm wondering why the cost for hepatitis B vaccine, the curve seems flat. Does it mean there was no demand for the vaccine?
No, it doesn't mean there's no demand. It just means that coverage is high in a lot of settings, and we're expecting to maintain a high level of coverage when you average out the number of the countries that we cover. So just because something is flatlining costs doesn't mean it's not being utilized or it's not being taken advantage of. It just means that the cost rate is not growing over the time period. The ones that it will be growing for are ones that either have very fluctuating prices associated with them, or ones that are newly introduced and we expect a startup period and a rapid scale up period because there's very low current coverage in settings now. So that's probably why you're seeing it look like it's a smaller proportion. It's not actually diminishing in terms of use.
Okay, thank you. It's
Quick
clearer now.
question, Brian. Did you consider the impact of herd immunity? And the other question is, it's very tricky to calculate loss of productivity in the low and middle income countries. So how do you manage to get those kind of data, please?
So a number of things. So as Libby mentioned, when we were talking about our economic benefits modeling process, we take into account estimates that were generated through epidemiologic models by a number of different entities who are grouped together under the Vaccine Impact Modeling Consortium, which is based out of the University or the Imperial College of London. But there's modelers and teams at universities all over. So they have different models that are specific to each of these antigens, and they're grouped together under this, which take into account all of the various epidemiologic factors that go in. Those models then generate death and disability associated with illnesses in each specific setting and country, which incorporates the different dynamics of the diseases. And then we use those disability and cases and deaths to create monetization of value. And so we described our approaches, how we monetize the different cases and deaths through either a VSL approach or a human capital based approach through cost of illness. But the data on, the cost of illness has to do with GDP or wage. We have a number of different ways that we've estimated trying to get a proxy for what the value of productivity and averted productivity is. Libby, would you like to describe in more detail any of that?
No, but I am seeing a lot of questions about the health impact models, including questions about whether timeliness of vaccines, vaccine delivery impacts the benefits. And as you said, Brian, there's a lot of diversity in the models that we use. And the models are constantly being updated in terms of their methods. But I would say that definitely all of these factors impact the results from the health impact models and also impact the high rate of uncertainty in these models. And I believe there's a publication from the Vaccine Impact Modeling Consortium coming out in the Lancet very soon that addresses a lot of these questions. And when we incorporated the uncertainty ranges from the health impact estimates into our model, we saw that there was the impact of the uncertainty heavily impacted our estimates as well. And we had very broad uncertainty bounds around the economic benefits results. So I think that there's a lot of variation between the models, and when we look at them as a whole, we do see that there is a very large impact of vaccination on cases and deaths, but there's also a wide uncertainty in these estimates.
I'll take another question here, which I think is interesting methodologically and about using these different numbers. So we all know about cost effectiveness. Like, cost effectiveness is probably the most common economic tool that's utilized in health. So one question here is, do you recommend ROI approach to decision makers from developed markets to inform their recommendation for immunization policies instead of cost effectiveness analysis? So I think the choice of what approach you use depends upon what you want to say about immunizations and what you want to compare them to. So I've reiterated in this discussion that cost effectiveness is a perfect method for evaluating two programs where the benefits are the same unit. So if you can measure the benefits in disability adjusted life years, in quality adjusted life years, in cases averted or deaths averted for all different things you want to compare, then cost effectiveness is a perfect tool to use to address that. You would need to adjust for other things. I mean, it's not perfect in terms of what it can encapsulate, but it's a good way to compare things. You can even adjust cost effectiveness for things like equity if you wanted to through distributive cost effectiveness analysis, distributional, or extended cost effectiveness. You could do the same things with ROI, but ROI gives you a little more flexibility when you'd want to compare to investments that don't have outcomes that are disability or mortality. So it's impossible to compare using cost effectiveness an investment in an education program with an investment in a health program in purely economic terms using cost effectiveness, because maybe education, most of the benefits aren't in the amount of death or disability that it prevents. It's in other things like broader social well-being, future earnings, and things like that. So ROI can help compare those two disparate types of investments, but within the health sector, cost effectiveness is by far the most common method used. Another question here is, people have been quoting earlier estimates of 16 to 1 for ROI. Can you now quote 28 to 1? Is this the new number? Andrew, can you go back to the slide with the different, this one, yes, and one more so the other side is showing. So 28.5 is the new 16.1 ROI estimate for what we anticipate, we see has happened from 2011 to 2020. So when the 16 to 1 number was generated, we were only about halfway through the decade of vaccines, and the projections for the remaining decade hadn't been done, and there have been updates to the way that things have gone in terms of the methods used for some of the calculations to be more consistent with methods that are used elsewhere. But a lot of this has to do with changing prices. Prices, particularly for many vaccines, were lower than anticipated when we were doing this analysis before in 2016, which is largely, we think, due to market shaping and other efforts to keep vaccine prices low. And we can really see that in this rising cost of illness number for that previous decade. What we're encouraging people to use for investment numbers, because these are, again, meant to kind of be advocacy for going forward, is this 21 to 1 or 20.6 to 1, where we're rounding it to 21 to 1. Is one estimate that we've been putting out quite a bit, because this is our new estimate for what we anticipate and hope to see in the future decade from 2020 to 2030. Here's one from, this individual is interested in an ROI for Sub-Saharan Africa. What's the process that we are considering for a country-specific approach, and who outside WHO and Gavi do you work with? There's a huge gap in economic modeling, and some of these countries haven't been able to establish the cost of immunization per capita. So currently in our new iteration of work, we are planning on working more with Uganda and Nigeria as countries specifically to expand up. So anybody who is involved with immunization work is more than welcome to reach out to us, and we can have a discussion about that. Through the Decade of Vaccine Economics project, we've worked very closely with Makerere University and Uganda to generate cost of illness estimates for pneumonia, measles, and diarrheal diseases in those settings. So we've done survey work to compute at different facility levels and different locations in different districts, the actual cost associated with treating cases of these vaccine preventable diseases, both from a facility and healthcare perspective, but also from the family's perspective and household perspective. So how much labor time was actually foregone? What kind of income was foregone by these households because they had to treat their children and stay home with their children and care for their child or bring them to a facility? What did they pay out of pocket for medications, if anything, and all that? So we've done some detailed in-depth cost of illness studies, and particularly for Dove in Uganda, but expanding, we plan to do additional work in other settings. And anybody who is interested in those types of collaborations are more than welcome to reach out. Here's a question. Are childhood health interventions predisposed to higher ROI cost effectiveness than other health interventions aimed at older populations? The answer varies. So it depends upon what the intervention is doing and how it's impacting the children particularly. So perhaps things that may have a higher mortality rate among older adults using a VSL method versus maybe a lower mortality rate, but some type of morbidity, short-term impact on children at a young age that could be severe, those may be more comparable. The one thing that there is a large difference for are diseases that primarily impact children and have a much higher mortality rate among children, which, as we all know, are many vaccine preventable diseases. They are more conducive to higher ROIs or cost effectiveness versus adult vaccines, because there's a longer period of averted life and maybe a higher mortality rate. Maybe the same illness has a lower mortality rate as an adult. So there are a number of different factors that could come into that. It's not always the case that just utilizing return on investment or cost effectiveness in general will always favor younger populations. It depends upon what the disease burden looks like.
Hello, everyone. Hello.
Hello.
Yeah, so please, I'm still going back to the earlier question related to the vaccines given timely vis-a-vis vaccines that are not on time because of the huge impact in terms of difference to the health outcomes. Whether or not this model you'll be able to have a much deep dive to be able to give us a much powerful argument that can push the agenda of timely vaccination, particularly in sub-Saharan Africa. Over.
So to date, timely vaccination question is not something that we've explored utilizing these models, but I would imagine, I mean, this would be something we would need to discuss with the FE side of this equation as well, but that this is something that may be possible to do a deep dive into in the future. Libby, are there any questions that you want to respond to? I know I'm answering a lot of them.
Yeah, yeah, I see an interesting one about looking at investments in health system strengthening. So the way that that is incorporated into this model is pretty specifically looking at improvements in investments in like cold chain capacity and investments directly related to vaccine delivery that are included in the delivery cost estimates. But this specific analysis does not compare to investments in health system strengthening. So it's difficult to take this analysis and then directly compare it to investments in other health interventions such as, and now I'm looking at another question, such as nutrition and primary healthcare interventions. But certainly when we look at the different return on investments, we see that many interventions have high and very positive high returns on investments, and other factors are also needed to weigh decision making. Brian, if you want to follow up on that.
Yeah, so definitely, these numbers are presented from this perspective so that decision makers can use this as one element in their toolkit for decision making. We're not offering this is the correct decision to make when you have to come down to the wire and make a decision, but we are providing evidence to people who are decision makers, displaying that this is one way to measure the benefits associated with vaccines that may allow them to be compared with other things such as nutrition or other PhD interventions. And additionally, even if all of these things are great and an individual or a country wants to invest in all of these things, these numbers can help to figure out which one to do first. which is another thing that they could be used for. Here's another question. When you do a study of cost offsets in healthcare costs, do you assume that all illness episodes would be treated? So related to that, there is a care-seeking rate that we apply. So we assume that there's a care-seeking rate assigned to the different types of antigens that we do based upon the settings, so that not everyone for all of these diseases is actually modeled to be seeking care. And that's how we incorporate that into our models by utilizing these care-seeking rates. Health benefits over economic benefits after COVID-19. Should we change our thinking? I think that we've been thinking in terms of health and economics in largely a positive way going into, the last 5 years, and the combination of these two things. I don't really think it's something that we need to do to necessarily change our thinking, but I do think it highlights that health sector and health related things have large spillovers. And spillovers are something that we maybe haven't done a good job of measuring historically for health programs. So just because something averts disability and death doesn't mean it doesn't also have all of these other benefits associated with it, which we try to capture in our VSL estimates. But there are even broader benefits, like because you're healthy, you attend more school and can get a higher education. Because you're healthy or vaccinated, you can do all of these other things that you may not have done before, which provide these spillover effects. So having a better idea of what the spillovers are and how all of these different things are connected into one system is obviously extremely important, which is related to these health system thinking, but a larger, social system thinking is very important. And I mean, ROI is one specific dimension which focuses on the monetary and effectiveness, but can be a component of this composite thinking, which I think will be continually important. It is now, was before COVID, and I think will be continued to be important after. Do changes in the types of health insurance program designs impact willingness to pay? So it depends upon the setting and the framing of willingness to pay questions. So there are a number of different things. Sometimes it can influence willingness to pay through what we would call a bias. So if something is typically free in a social healthcare system and you ask someone how much they're willing to pay for that, because it's typically offered for free, people may say zero. That doesn't necessarily mean they were willing to pay $0 for it. It's more of a protest zero that we call it in the literature, which is saying that I'm used to paying $0 for it, so I only want to pay $0 for it. But maybe if they hadn't been given it for free, they would be willing to pay $30. Willingness to pay really wants to get at what would you be willing to pay if nobody offered it to you for free? Because that's what we want to capture. We want to capture how much benefit in dollars do you associate with the benefits that that product provides you. So if you have health insurance and you're more likely to say zero because you're covered and it's free for some reason, then that may influence your willingness to pay. There's another reason why having health insurance that's widely known in the economics literature may impact both your behavior in health and decision-making, which is this sort of moral hazard idea. Like, because you're protected against potentially severe outcomes, maybe you make more risky decisions. That's not proven in all that's not proven in all settings, but it is a relation. I think I hear someone who's unmuted.
तो एक प्रैक्टिकल मैंने वो बनाया है सबको लेके लैब वाले को mute all the participants. तो हम उसको पीडिया के नहीं बाकी लोग भी रहेंगे, नर्सिंग वाले भी रहेंगे, तो मैंने उसने एडवर्टाइजमेंट दिया ना, तो आप हम उसको क्या नाम दें, जरा पीडियाट्रिक्स का नहीं रहेगा ये.
So there's this idea of moral hazard where potentially people who are covered in insurance could engage in more risky behavior than they would otherwise. Again, this is setting specific, depends upon a number of different things, but that's another way that potentially the interaction between behavior and willingness to pay may be related to insurance. So it varies largely setting to setting.
Looks like Mark Miller wants to speak.
Yes, thank you. I had sent in a question. You had shown on your graph the cost per antigen, and it looked like measles was quite high, relatively speaking, and I was curious about that. The second question relates to your statistical valuation of a life of around $10 million. And I assume that's without potential regard to the number of years. And I was wondering, how realistic is that figure? The World Bank historically used figures for about 3 times GDP for a year of life lost for something to be considered cost effective. So how does that compare to a valuation of 10 million using US as an index?
Perfect. Yeah. So the US VSL from the 10 million estimate comes down to about $285,000 a year, which is, or actually, I think it's $175,000 a year, which is approximately 3 times US GDP per capita, a little bit higher. So not so far off from that. When you do various discounting for that, it winds up being, you know, about what those thresholds would correspond to. The 3 times per capita GDP thresholds for cost effectiveness are, again, like meant to kind of encapsulate what is done directly in the VSL, is capture the broader benefits behind GDP per capita and behind a health investment. So 1 times is cost effective, less than 1 times is highly cost effective, less than 3 times is cost effective. But ultimately these relate. So the VSL approach, again, goes into this and applies by life year rather than the overall value of life that we get from the US. So they're all based around this kind of similar logic that life has a value more than 1 times per capita GDP, and how we get that is based upon either of these values. There was another part to that question, which I'm forgetting the first part.
It was related to the graph that you had shown of
the measles.
Cost per antigen, and measles looked disproportionately high considering the cost of the antigen. I don't know if it's because of administrative costs, but it seemed relatively high compared to, for example, HPV or pneumococcal vaccines.
Yeah, so one of the reasons for the measles cost as it is in a number of our countries, measles is commonly delivered through campaigns. And so there's the additional cost of campaign delivery versus routine delivery. But if you take a look at the overall cost, I don't think it's hugely disproportionate to a number of things. But again, one of the cost factors going into it has to do with this this campaign delivery style in a number of settings and the costs incurred by campaign delivery. Similarly, we get on the benefits. It's noted that measles produces a large proportion of benefits in many countries compared to others in terms of economics, which is because of the high case fatality rate in early childhood for measles.
Thank you.
Yep.
I think we're right about time. Do you want to go through the last few slides here?
Yeah, sure.
Okay.
So for more information on this project and other things that we've been contributing to under the Decade of Vaccine Economics, you can visit our website at immunizationeconomics.org for the Dove homepage to see all the different components. We discussed here the return on investment and cost of illness estimates related to that in VSL, but we also do sub-studies in a number of countries that get very specific data on cost of illness averted by region, by socioeconomic quintile, and we pilot methods for measuring value of statistical life in Bangladesh, and that data is also available there. We have